Well, welcome to episode 4 of the Cutting Edge series. I'm absolutely thrilled that we have a friend and colleague of ours from the UK, Professor Mark Coleman. Many of you will remember Professor Coleman from his integral part and work that he did in the LapCo training program in the UK, which essentially trained up the colorectal workforce with laparoscopic colorectal surgery. But he's now moved on to the head of JAG, and that is the governing body for endoscopy in the UK. So we're hoping that we're going to get a great fireside chat here with Mark, who's going to tell us a little bit about the past, something about the current, and hopefully a lot about the future. As usual, I'm joined by my co-host, Dr. Venki Munakrishnan. So hello, Venki.
All good, all good. Good to see you guys. Welcome, Professor Coleman.
Yeah, interestingly, I think Mark was one of your old mentors and consultants. So it'll be, so it adds a little bit of extra spice to the interview. And of course, welcome, Mark.
Thank you very much. Thank you very much. It's great to join both of you, and been watching both of your careers with enormous interest. And Venki, obviously, remembering you from your time in Plymouth.
Absolutely.
Well, let's see. Hopefully we can do you proud, Mark. So look, let's kick off with the first question. As I said in the intro, the LapCo work that you did was revolutionary in the UK. And I think a lot of what we learned from LapCo, the modular training, the use of gas forms, I mean, this has been replicated in many countries worldwide in terms of the training program. Just tell us a little bit about how that all started and how you've managed to evolve that into current training needs of trainees in 2020.
Okay, well, referencing laparoscopic colorectal surgery and its history, as you will know, through the 90s when it began to become popular, it was realized that there were problems. I guess they can be summarized two ways. One with reference to how people taught themselves laparoscopic surgery and its associations with poor outcomes. And we remember with laparoscopic cholecystectomy when it first came, how self-taught surgeons really had very poor outcomes, which could be measured in things like common bile duct injury and conversion to open. And then when laparoscopic colorectal came around, there were the stories by the mid-90s of poor oncologic outcomes like port site metastases. And that led both the British, European societies and North American societies, more or less collectively and individually, say that they felt that laparoscopic colorectal surgery was too dangerous for people to learn, certainly in the same way. And in fact, our own UK National Institute for Health and Care Excellence, NICE, in 2001 recommended that there wasn't sufficient evidence to support the use of laparoscopic colorectal surgery out of trials. This really changed and did a complete about-face internationally in the early 2000s because of the various multinational randomized studies, particularly classic, color and cost, together with other trials from Asia and Australia. And by mid-2000, pretty much all of the same societies were recommending the use of laparoscopic colorectal surgery. And this was echoed by NICE, who said in 2006 that suitably trained surgeons should undertake laparoscopic surgery on appropriately selected patients. What the healthcare community and the UK government realized in the mid-2000s that by doing this through an uncontrolled see one, do one, teach one process would result in those poor outcomes that were terrifying surgeons at the same time. And what was needed was a properly structured training program that gave consultant colorectal surgeons in the UK access to an expert to help them with their training. And what we realized early on, and what we really realized through LapCo, what we needed was a verifiable, guaranteed, reliable way to guarantee the competence of a laparoscopic colorectal surgeon. And that's really what we built in terms of the LapCo program, a hands-on supervised training program for surgeons carried out by acknowledged experts in laparoscopic colorectal surgery and accompanied by appropriate forms of assessment, as in the gas form that you've mentioned, Manish.
So before I know that Venki will be itching to ask you how that translates to robotics and how we can see that with the popular rise of robotic surgery. But in your experience, I mean, this is not necessarily from the literature, but from what you saw, where was the problem and the difficulty in training laparoscopically? What were the difficult parts of the operation, and also the parts of the operation which trainees found difficult to understand from their trainers? Because just because you watch a procedure, trying to understand how to do that technically doesn't always translate.
Yeah, and I suppose the obvious thing there would be that surgeons, trainees, and specialists, surgeons, consultants, whatever you want to call them, would watch videos of procedures and assume, because they had the underlying laparoscopic and open skills, that they would be able to undertake these procedures. But at the very simplest end of the spectrum, in setting the patient up on the table, the three of us and our colleagues know that this is one key step, that if you get it wrong for laparoscopic colorectal surgery, you will fail throughout the procedure. So having the patient safely secured on the table and being able to move them into positions safely of side tilt and head up or down tilt are absolute keys to successful surgery. And then during the surgery, being able to adequately expose the vascular pedicles to do a medial to lateral dissection, especially in a challenging obese patient with previous surgery. These are key steps that have to be achieved before you even begin to do the dissection of any vascular pedicle or flexure.
Mr. Coleman, so great to see you, and I miss my days in Plymouth, and it was one of the busiest hospitals in the UK, and the amount of colorectal surgery I saw, and you guys trained me there, and it was just phenomenal. And whatever I'm doing today, I think part of the success will always be with Plymouth and your team. Thank you for that, and I have very fond memories of it. But let me take you back to those days. This was 2003, 4, 5. When LapCo was set and you as a director were taking it forward. We had consultants coming in, getting trained, and you were going out to train them. And then you also had senior trainees and junior trainees like me just coming into the training programs. And it was fascinating to see laparoscopic surgery so, as you rightly put it, sort of formalized, setup, assessment. But it must have been really challenging, to keep everybody happy. And, how did you manage that? Because that's going to reflect on robotics as well when new technology is coming in.
Well, if you go back to the 90s, and I'm afraid I'm old enough to have been an SHO in the early 90s when laparoscopic cholecystectomy, hernia repair, appendicectomy were being carried out largely by consultants, and senior registrars, residents, fellows were lucky to get anywhere near a procedure, let alone an SHO. The lesson we learned was, as soon as you can safely train senior colleagues, more senior colleagues, to do procedures, they then will be able to train others. So I think what we've learned is that by having a good, well-structured, efficient, and effective training program, you get the more junior colleagues closer to being trained than by having an old-fashioned sort of apprentice-style thing where the junior people just get shunted to the side. So that's the first thing. The second thing, and this really applies to robotics, is there is currently a gap in robotic surgical training, which is largely applied to consultants or surgeons, specialists, whatever you like to call them, in what they achieve from the current training program rolled out by the main companies or company that provide this, and them being an identifiable point of being competent to do complex surgical procedures. And I'm afraid one has to identify and highlight the disaster that occurred in the northeast of England, where a robotic cardiac surgical procedure ultimately led to the death of a patient. And the problem, as I've heard, is that there was, I think, an insufficient guarantee and identification of competence in the surgeon performing the procedure. And you need to have a verifiable form of training with an expert supervisor in the operating room who then signs that person off as competent. So it's that very critical phase when you start to learn a procedure to the point where you're competent to perform it independently that must be reliably guaranteed, number one. The next thing is, how do you guarantee the competence of the trainer? When the LapCo program started, we soon recruited 70 so-called experts in laparoscopic colorectal surgery, largely self-identified as being experts. And what we realized is that they all had very different inclinations and expertise as trainers. And we realized we needed to train them to be better trainers, to perform a higher level of training and to standardize it across the board. And that's where the LapCo Train the Trainers course came from. And that is now being replicated in many ways in robotic surgical training to make sure you have a faculty of competent trainers who focus on the trainees and say, what are their needs? How do we get them to a point of competence?
I've got another important question for you, because I think it comes up in every meeting. It comes in lots of discussions, because I don't think there's anybody else better in the world to answer this because of your experience with LapCo and your current support for robotics and its training. Does having laparoscopic experience help if you're going to do robotics? Because there is a discussion saying you can jump from open to robotics and you don't need to have any laparoscopic experience. But I personally think watching you do all that in those early days and then building up on my own program, I thought knowing where your instruments are three-dimensionally, you learn that from laparoscopy. I want to know what you think about that.
I think that's a very good question, Venki. And I think the answer is that robotics in its current format and with future development will help open surgeons transition to minimal access surgery easier and quicker than they may be able to do so through laparoscopic multi-instrument surgery. But I think that a laparoscopic surgeon will make that transition much easier and quicker. I think the big question is, will robotics, make the jump to being the mainstream for complex surgery? I think the chances are, and the answers to that are certainly in well-developed countries. The answer is yes. Will it transition to that position for all laparoscopic surgery? That seems hard to believe currently, but we know that technology is becoming cheaper and more widely available. Other companies are coming to the market, so it's certainly possible. And I think the other challenge is obviously looking at developing in undeveloped countries and seeing how we can get training into those societies. What societies and what I'm really impressed by is with our projects that are currently covering more than 100 countries through LapCo, is how joined up and interested countries from Asia, from Middle East, from Africa are in advanced laparoscopic surgery, and moreover in advanced techniques of training and of things like flattening hierarchies, getting rid of old patriarchies. I think these are really important things that are of much greater interest than they were even 5 years ago.
Well, thank you, Mark, on that journey through LapCo into robotics and the good work that you're doing around the world by continuing that program and the great success, of course, that has brought to many units in terms of training. But let's transition then from LapCo into JAG, as you have done so. So you've gone from using, I suppose, or you've taken your experience from LapCo and hopefully now applying that to the world of endoscopy in the UK. So how did you get into that role with JAG, and what do you hope to bring to endoscopy at a time when we're seeing, particularly this year with the coronavirus pandemic, colonoscopy resources in particular were hugely problematic, and really, that was the pinch point when it came to, when you look at critical pathway analysis of what was going on in terms of colorectal cancer diagnosis. That was a real pinch point. So what do you hope to bring to this role going forward?
Well, another great question, and thank you for asking it. I mean, people might wonder why I would become chairman of a GI endoscopy, organization in the UK, but there are many synergies. After all, this endoscopy, flex endo, if you like, and laparoscopic surgery are both techniques and procedures that require great visuospatial awareness, 3D orientation, and great skill and great judgment, and they need good trainers. And we learned from LapCo that when we required, a bespoke hands-on interactive trainers course, that the best thing on the market was the version that's run by JAG called the trainer colonoscopy trainers course. And we used, with the help of the then chairman of JAG, Roland Valori, the trainer colonoscopy trainers course, TCT, and reimagined it and reprovisioned it for laparoscopic colorectal. And that's where LapCo TT came from. And I think because of that, and this identical challenge, if you like, of identifying, guaranteeing, and verifying the competence of practitioners that applies so heavily to endoscopy and laparoscopic surgery. They are, after all, forms of image-based intervention. That's why it seemed a very natural role for me to take up, and I was very excited to be interviewed and then get the job of chairman for JAG. And within 2 months of taking it up, we were hit by the tidal wave of coronavirus. Now, I mean, JAG covers the devolved nations, including England, Scotland, Wales, and Northern Ireland, but also has programs in terms of national endoscopy training assessment in countries like Ireland and New Zealand. So we have quite a broad reach, and we have trained the colonoscopy trainers courses going all over the world, particularly countries in Scandinavia and Canada, for example. So there's a truly international reach, and a lot of those groups of clinicians, really look to JAG for guidance, as do the British Society for Gastroenterology, the associations of coloproctology and upper GI surgeons, and other groups. So when coronavirus hit us, we started to develop guidance at the beginning, for example, the suspension of all non-urgent procedures, because many of these are aerosol generating procedures, the triage of 2-week wait referrals, the provision of protective equipment for staff. And then as the pandemic rolled forward, we then developed guidance on the restoration of services slowly at the beginning, and then how to grow services and make maximum use of resources to make sure that services and waiting lists could be resurrected and dealt with as soon as possible.
Mr. Coleman, so the next question is, again, is related to endoscopy, and it's a question I think will resonate around the world. Who should be doing endoscopy? Is it surgeons, physicians, or there is a role for both of us to work together, collaborate, and do different things? What's your view on that?
Well, my view is that anybody that's been properly trained and is verifiably competent to perform endoscopy should be doing it, and it shouldn't be referenced to your specialty or background. It's as simple as that, and that is the JAG view and has been for many years. And throughout JAG has been around for more than 25 years now, since 1994. The chairmen and the committees have been composed of both surgeons and physicians working together, reflecting the nature of endoscopy in the United Kingdom. I know that throughout the world, the provision of endoscopy services varies, and in some countries it's 100% physicians, and in other countries it's dominated by surgeons. But for us, it's more about training and competence, and then ongoing appraisal and audit to make sure that your key performance indicators are appropriate and maintained.
Right. So as we go forward with technology and endoscopy, the field of endoluminal surgery and robotic endoluminal surgery is taking shape. Cleveland Clinic has already started an independent department for endoluminal surgery. And as surgeons, obviously, we do lots of cutting out stuff. So ESD and EMRs. So I just see a synergy there where teams could come together, physicians, surgeons. So can you highlight on that for us?
Certainly can. I mean, just drawing back a second, I think in a decade or two's time, fewer diagnostic flex endo procedures will be carried out for diagnostic only purposes, and NHS England and JAG are supporting a rollout of colon capsule endoscopy, and that will be particularly applicable in parts of the world where access to healthcare is poor. therefore diagnostic colon capsule endoscopy may have a key role, and that's certainly been the case in the Highlands of Scotland. Yes, you're absolutely right. For complex interventional endoscopic procedures, there's a role for people adequately trained to do endoscopic mucosal resection and ESD. Again, it's more about the competence and training than the specialty for me. And there's definitely a role for surgeons to play. Certainly in the UK, ESDM are mostly carried out by physicians. I guess that just reflects the kind of skill mix and job planning that goes on, whereas surgeons tend to be, for all the right reasons and the obvious reasons, are drawn more towards the operative side of things and robotic side of things, again, as they should be. But I think there's grounds for a happy marriage, if you like, of the specialties where, you know, good quality multidisciplinary team meetings decide where and how the patient should be adequately treated. And again, that's been a great and often undersold success of the landscape in the United Kingdom, with really good functioning multidisciplinary teams.
So one more question to finish off this segment. So training has always been a challenge for colonoscopy, because finding lists, lots of trainees.
Yeah.
Because I remember when my time in Plymouth, we had lots. I mean, we were a very busy hospital, so we had access to it. But so the same thing is going to apply for robotics or laparoscopy. So access to it now, with all this virtual technology, technology such as Proximy, where you could teach people remotely. What are the things which are happening, which you are considering in endoscopy or robotics?
Yeah, so, good questions again. Just talking about coronavirus and training, for example, we pushed very hard and quite early to make sure that every endoscopy facility in the United Kingdom that could be used is being used to resurrect endoscopy and make sure that waiting lists were addressed to deal with the problem that arose from the pandemic. So that's number one. Second, we said that anyone that's in reaching distance of accreditation for endoscopy should be encouraged to go to training lists, and where appropriate, these are even being provided in the private sector, to make sure that people that are close to the line and obtaining their certification should be doing those lists. And that I've seen some very successful stories around that. JAG is blind to whether you're a surgeon or physician, including post-pandemic. We think that both specialties should have access to training lists. And there's a push and the pull. We can push trainees and training units to provide capacity, but we must allow trainees also to take responsibility for themselves and make sure they make themselves available for training lists as well, and reach out to their endoscopy training leads and senior nurses to make sure they're available for those lists, so they can get themselves up to the required level.
Great.
So Mark, I think we've seen a difficulties you mentioned with diagnostics during the pandemic. One thing certainly we've all seen in the UK is the triage now being done by the use of quantitative fecal immunochemical testing, QFIT scoring. And there's been a very good article recently published in Gut by the Croydon Research Group with Muti Abalafi leading on that study of about 10,000 patients looking at QFIT values. How do you see some of these more accurate screening or surveillance tests being used in the future to better triage the use of endoscopy, and particularly colonoscopy, which of course, at times like this, it is found to be challenging?
Well, let me give you two broad brushstrokes. Reaching back, a couple or more decades, the 2-week wait referral service in terms of the diagnostic yield of cancers for lower GI has been a failure. Any figures that you read from any form of research show you that the yield of cancer from colonoscopy in that pathway has really been around 5%. When it was designed to have a yield of, in some cases, over 30% for elderly patients with suspicious symptoms of having colorectal cancer. So by any measure, the whole pathway has failed in terms of diagnostic yield. Then you march forward to the advent of the pandemic, and it's really created some enormous problems. But I'd like to think that it's also given us some really potentially great opportunities. And one of those has to be to incorporate a sensible form of triage of symptomatic patients based on FIT, and therefore allocate them to forms of investigation that are likely to result in a greater diagnostic yield of colorectal cancer, which may or may not involve the use of other things like colon capsule endoscopy as well. So I haven't seen the figures from the Croydon trial specifically, but I've certainly seen the various ways of triaging using FIT-based levels, dosage levels, and I think it's potentially an exciting prospect for us to make better use of our resources for two-week wait referrals.
Because one of the things that I suppose us and others struggled with between April and perhaps June, July time was the shifting goalposts when it came to FIT levels, whether that be 150, 50, 10, lower than 10. And
right.
if you were in, my understanding of it is that if you get a particularly high value, there's probably something sinister going on. And if you get a particularly low value, then you're probably clear of colorectal cancer. But when you're in that sort of 10 to 50 group, or even 10 to 150, do you perform an alternative examination? Do you use a CT scan? And I suppose what you're really saying is that we need something which is accurate, but that doesn't mean that it's necessarily a substitute for colonoscopy on the background of the 2-week wait in itself, which we know has been problematic and has had a low yield. Is this streamlined pathway of 2-week waits, is that something that we should abandon and just use things like QFIT to determine when people get tests?
Well, I think most places pretty much have and are still sticking to a FIT-based method of triaging two-week wait criteria, referred patients. But I think the answer is I don't really know yet, and I think we need to do more research, and I think ultimately this needs to form the basis for how we go forward in terms of looking at patients who are symptomatic, using FIT, and then determining what kind of investigation is needed and at what interval. But we've also always got to remember that these are essentially guidelines and encourage GPs to see them in that way, whilst also providing non-2-week wait pathways that give them sufficient capacity and confidence that they can still have patients seen by a specialist if they want, either gastroenterology or colorectal, to see if they have a problem which may be related to neoplasia or something completely different, but nevertheless legitimate for a referral and an assessment by an expert.
Well, look, I think that's been an absolutely fantastic discussion on training across laparoscopic, robotic, and endoscopic pathways. I'm going to leave the last word with Venki, who I know wants to ask you something about haircuts and theatres and operating theatres. But thank you very much, Mark, for joining us. For all the viewers out there, hit the subscribe button for additional content and also the full-length interviews across the series. And I will leave the last word with Venki. Thank you very much, Mark.
Mr. Coleman,
thank you, Manish.
Mr. Coleman, thank you so much for sparing your time. I have very fond memories, as I said earlier, about Plymouth. It was my second year of training, and I came and saw the amazing laparoscopic work you did. And also, when you're busy theater list, you used to have a haircut, and I thought, okay, when you arrive, you have your haircut in theaters. So, I'm working towards that. But, those are fond memories, and thanks for sharing your life experiences, or work experience rather, with us, because it's like a journey through time. Thank you.
Well, thanks to you both for your very kind invitation to join you on this exciting venture, and I look forward to further opportunities with both of you. Thanks very much.